21. A 7-year-old girl with several noticeable skin lesions and reduced unilateral visual acuity showed fusiform swelling of the optic nerve on a CT of the head performed out of hours after a fall down a flight of stairs. MRI orbits revealed a thickened optic nerve with signal intensity similar to gray matter on T1W and T2W images, with a variable amount of contrast enhancement. What is the underlying phacomatoses? A. Mimics. Radiographics. 2011, 31:2021 34. 21. B. Neurofibromatosis type 1. The imaging appearance of optic nerve gliomas is characteristic, such that biopsy is rarely performed. MR imaging is the modality of choice, particularly for assessing involvement of the orbital apex, optic chiasm, hypothalamus, and other intracranial structures. The lesions are typically isointense on T1 weighted images and isointense to hyperintense on T2 weighted images. Enhancement is variable, and cystic spaces may be seen. Calcifications are rare. A rim of T2 hyperintensity is often observed at the tumor periphery, a finding that may mimic an expanded subarachnoid space. However, this finding corresponds histopathologically to leptomeningeal infiltration and proliferation, so-called arachnoidal gliomatoses. The appearance of optic nerve gliomas is different in patients with and without NF1. In patients with NF1, the optic nerve often appears tortuous, kinked or buckled and diffusely enlarged. In patients without NF1, gliomas tend to be fusiform. Isolated chiasmal gliomas are more likely in the absence of neurofibromatosis, and chiasmal involvement is also more common in patients who do not have neurofibromatosis. A. Neurofibromatosis type 2B, neurofibromatosis type 1 center von Hippel-Lindau disease D, tuberous sclerosis E, Down syndrome. 22. Fetal MRI usually is performed in a scanner with a magnet strength of A, 0.5 Tesla B, 1.5 Tesla C, 1 Tesla D, 3 Tesla E, 0.1 Tesla. 23. A patient arrives in the A&E department having been involved in a road traffic collision. He is hemodynamically stable. The Glasgow Coma Scale, GCS, at the scene was 14. On arrival in A&E, he is found to have a bruised left forehead. He suddenly becomes unresponsive with a GCS of 4 and is intubated. As the on-call radiologist, you are called to perform a head CT. Which of the following would make an epidural hemorrhage least likely? A. Biconvex hyperdensity B, overlying skull fracture C, crossing of suture line D, homogeneous fluid of 50 Hu E, homogeneous fluid of 80 Hu. 24. A 12-month-old presence with loss of appetite. Neurofibromatosis. Taylor TD, ETAL orbital neoplasms in adults, clinical, radiologic, and pathologic review. Radiographics. 2013, 33, 617 39 58. 22. B. 1.5 Tesla fetal MR imaging is routinely performed on 1.5 T Mr scanners. Glenn O.A., Barkovich A.J. Magnetic resonance imaging of the fetal brain and spine, an increasingly important tool in prenatal diagnosis, Part 1. AJNR AMJ Neuroradiol. 2006, 27:16 0411. 23. C. Crossing of suture line epidural, extradural. Hematomas do not generally cross suture lines, unless associated with a diastatic fracture of the suture. Extradural hematomas are biconvex, extraaxial fluid collections associated with skull vault fracture. Fresh blood is 30-50 Hu, coagulated blood is 50-80 Hu. Dannert W., Radiology Review Manual, 6th N. Philadelphia, Pa. Fever and shortness of breath. Chest X-ray demonstrates a well-circumscribed paraspinal mass with a sharp pleuropulmonary surface. There is some calcification within the mass, and the intercostal space at that level is widened. What is the most likely diagnosis? A. Bronchogenic cyst B, neuroblastoma C, ganglioneuroma D, left lower lobe pneumonia. Pneumonia E, teratoma. Pa, Lippincott Williams and Wilkins, 2007:286. 24. B. Neuroblastoma. About 34% of mediastinal masses are posterior, and 88% of these are neurogenic in origin, most of which arise from the ganglion cells in the paravertebral sympathetic chain. The remaining 12% of posterior mediastinal masses are foregut cysts, malignant lymphoma, Hodgkin disease, or non-Hodgkin lymphoma. Neuroblastoma is most common in the under 5-year-olds, and ganglioneuroma is most common in those older than 10 years. Radiographic appearances are as described in the question. Cross-sectional imaging is useful to delineate the extent of the mass and any spinal involvement. Left lower lobe pneumonia can be confused with tumor, and this is a known diagnostic pitfall. Bronchogenic cyst is typically middle mediastinal. Merton D.F. Diagnostic imaging of mediastinal masses in children. AJR AMJ Rentgenol. 1992, 158:825-32. Chapter 10. Test paper 5, answers. 273. 25, D, single shot. Teratoma. 25, fetal MRI is most commonly organized to evaluate Inconclusive but potentially significant findings detected on ultrasound or to characterize definite abnormality detected on anomaly scan. Which one of the following MR imaging sequences is the most popular for fetal imaging? A. Fast spin echo T1W images. B. Stir C. Fat suppress T1W images. D. Single shot, fast spin echo, SSFSE, T2W images. E. Flare. Single shot, fast spin echo, SSFSE, T2W images. Because fetal MR imaging is performed without maternal or fetal sedation, image acquisition is susceptible to fetal motion. Therefore, fetal MR imaging is performed primarily using ultrafast MR imaging techniques known as single shot, fast spin echo, SSFSE, or half Fourier acquired single shot, turbo spin echo, haste. Using these rapid pulse sequences, a single T2 weighted image can be acquired in less than 1 second, reducing the likelihood of fetal motion during image acquisition. Because each image is acquired separately, fetal motion typically affects only the particular image that was acquired while the fetus moved. Glenn O.A., Barkovich A.J. Magnetic resonance imaging of the fetal brain and spine, an increasingly important tool in prenatal diagnosis. Part 1. AJNR AMJ Neuroradiol. 2006, 27:16:0411. 26, a 45-year-old man with proptoses of the right eye is referred for an MRI for further evaluation. MRI reveals uniform swelling involving all the extraocular muscles and a markedly dilated superior ophthalmic vein. What is the likely diagnosis? A. AVM of the optic nerve. B. Carotid cavernous fistula. Chapter 9. Test paper 5, questions. 247. C. Hemangioma. D. Lymphatic malformation of the orbit. E. Thyroid ophthalmopathy. 26. B. Carotid cavernous fistula. Carotid-cavernous fistulas are abnormal communications between the carotid artery and the cavernous sinus, either directly or via intradural branches of the internal or external carotid arteries. The pattern of venous drainage, either anterior into the ophthalmic veins or posterior into the petrosal sinuses, often dictates the clinical findings and radiographic appearance. Anterior drainage typically leads to the most dramatic ocular findings and enlargement of the superior orbital vein, the latter often detectable with CT or MRI. However, superior orbital vein enlargement is not specific to CCF. Additional radiographic findings with variable prevalence include lateral bulging of the cavernous sinus wall and enlargement of extraocular muscles on CT or MRI, and abnormal cavernous sinus flow voids on MRI. Direct visualization of flow-related hyperintensity on the source images of three-dimensional time-of-flight MRA can be extremely helpful in CCF detection, with 83% sensitivity and 100% specificity, far superior to standard MRI. Rucker J.C., ETAL magnetic resonance angiography source images in carotid ophthalmopathy. 27, a 4-day-old infant presents with poor feeding and lethargy. She was born at term following premature rupture of membranes. Chest X-ray demonstrates bilateral patchy infiltrates with small effusions. What is the most likely diagnosis? A. Hyaline membrane disease. B. Meconium aspiration. C. Transient tachypnoea of the newborn. D. Group B streptococcal pneumonia. E. Congenital listeriosis. 28. Cavernous fistulas. BRJ Ophthalmol. 2004, 88-2311. 27. D. Group B streptococcal pneumonia. Group B streptococcal pneumonia is associated with premature rupture of the membranes during labor. The disease may have an early onset with septicemia and fulminant progression to severe respiratory distress, shock and respiratory failure within 24 hours, or a late onset 12 weeks after birth, which is frequently associated with meningitis. Neonatal pneumonia can closely mimic hyaline membrane disease clinically and is the most frequent cause of septicemia in the neonate. Infection may resemble hyaline membrane disease very closely, especially in smaller infants. However, extensive granular confluent infiltrates, whose distribution is often less uniform than those of hyaline membrane disease, are more commonly seen. There is also less atelectasis than in hyaline membrane disease. Pleural effusions are not uncommon, and the lung volume is normal. The differential diagnosis includes hyaline membrane disease, which usually has a uniform distribution of pulmonary opacities, never has pleural effusions, and has a decreased lung volume. Meconium aspiration, which usually has nodular non-homogeneous densities, may have pleural effusions and usually has an increased lung volume. And finally, transient tachypnoea of the newborn, which usually has non-homogeneous densities and may have pleural fluid. Arthur R. The neonatal chest X-ray. X-ray. Pediatric Spur Revelation 2001, 2:31120. 28. All the following statements regarding Hrct changes in cytotoxic drug-induced lung disease are true, except A. Bleomycin toxicity has a poor prognosis. B. Paclitaxel is associated with pulmonary injury. C. There is no correlation between carmustine dose and toxicity. D. Diffuse alveolar damage, DAD, is the most common manifestation. E. Bleomycin toxicity can be increased by concomitant oxygen therapy. (23) 28. C. There is no correlation between carmustine dose and toxicity. Cyclophosphamide and busulfan are the most common drugs that cause lung injury. Diffuse alveolar damage, DAD, is the most common manifestation of cyclophosphamide-induced lung disease, with NSIP and COP being less common. There is no relationship between development of lung injury and dose and duration of therapy. Chapter 10. Test paper 5, answers. 274. Carmustine is one of the few drugs for which there is a clear relationship between cumulative dose and lung injury. Lung injury can occur at low doses if the patient has undergone thoracic radiation therapy. DAD is the most common manifestation, with NSIP being less common. DAD is the most common manifestation of bleomycin-induced lung disease, with NSIP and COP being less common. The risk of developing lung injury is increased in the elderly, in patients on oxygen therapy, with a history of prior thoracic irradiation, or in whom therapy is restarted in 6 months of discontinuation. The prognosis is poor, with most patients dying of respiratory failure within 3 months. Paclitaxel may commonly cause pulmonary toxicity. Rossi SE, ETAL pulmonary drug toxicity, radiologic and pathologic manifestations. Radiographics. 2020, 5/12/45-59. 29, C. The fat ring sign omental infarct. Therapy. 29. A 66-year-old person is sent for an urgent CT of the abdomen post-contrast. The CT is unremarkable apart from inflammatory stranding in the omentum. No peritoneal nodules or ascites are detected on the CT, and the report states possible omental infraction. All of the following are expected to be seen on the CT, except A, cake-like or whorled structure of mixed attenuation B, small amount of free peritoneal fluid C. The fat ring sign D, minimal reactive lymphadenopathy E, haziness of the fat anterior to the colon. 30. Infarction demonstrates a variety of imaging appearances on CT. Classically, it appears as a fatty, large, greater than 5 cm, encapsulated mass, with soft tissue stranding adjacent to the ascending colon. Early or mild infarction may manifest as mild haziness in the fat anterior to the colon. Omental torsion is a rare cause of omental infarction and occurs when a portion of the omentum twists upon itself, leading to vascular compromise. In omental torsion, swirling of the vessels is often visible within the omentum. Although most cases of omental infarction are on the right side, left-sided infarction also may spontaneously occur. Unusual locations of infarction are more commonly seen in the setting of surgical trauma or post-operative changes that result in altered omental vascular supply and subsequent infarction. Similar to epiploic appendicitis, the adjacent colon is usually spared, although rarely the colonic wall may be thickened, a result of direct extension of omental inflammation. The fat ring sign is seen in epiploic appendicitis, not omental infarction. COM-A, ETAL imaging manifestations of abdominal. Skeletal survey is performed on a 2-year-old boy with short stature. The lateral film of the spine reveals abnormal vertebral bodies with a central anterior beak and generalized flattening. Radiographs of the hands shows a pointed proximal fifth metacarpal base with a notch at the ulnar aspect. Which of the following is the most likely diagnosis? A. Hunter syndrome B. Hurler syndrome C. Morquio syndrome D. Achondroplasia E. Nail patella syndrome. 31. Which one of the following statements regarding rheumatoid arthritis? Abdominal fat necrosis and its mimics. Radiographics. 2011, 31:2021 34. 30. C. Morquio syndrome. The mucopolysaccharidosis are a group of inherited diseases characterized by abnormal storage and excretion in the urine of various mucopolysaccharides. These patients have short stature and characteristic plain film findings. A characteristic finding in the hands is a pointed proximal fifth metacarpal base that has a notched appearance to the ulnar aspect. There is generalized flattening of the vertebral bodies, Pleiades pondyle, cf. not a feature of Hurler syndrome. Hunter and Hurler syndromes demonstrate an anterior vertebral beak that is inferiorly positioned, whereas Morquio syndrome demonstrates an anterior vertebral beak that is centrally positioned. Although achondroplasia can cause rounded anterior beaking in the vertebra of the upper lumbar spine, the findings described within the hands are more typical of the mucopolysaccharidosis. Brantwe, Helm C.A., Fundamentals of Diagnostic Radiology, 3rd ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2006. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011. 31. C. COP is a recognized pattern on Hrct in rheumatoid lungs. Thoracic. Arthritis-associated thoracic manifestation is true. A. Thoracic involvement occurs early in the disease. B. Pleural effusions is usually bilateral. C. COP is a recognized pattern on Hrct in rheumatoid lungs. D. Fibrosis mostly affects the upper lobes. E. Cavitation in nodules suggests some other disease. Thoracic involvement develops in patients with disease progression. Pleural disease is the most common thoracic manifestation and pleural thickening is the most common finding, more than pleural effusion. Pleural effusions are usually unilateral and may be loculated. They usually occur late in the disease and are commonly associated with pericarditis and subcutaneous nodules. Hrct shows basal and peripheral predominant fibrosis. Rarely upper lobe fibrosis, mimicking tuberculosis, TB, can occur. There is increased prevalence of lung cancer in fibrotic rheumatoid. Chapter 10. Test paper 5, answers. 275. Lung disease. Nodules are multiple and well circumscribed, often forming thick-walled cavities. Obliterative bronchiolitis results in air trapping and mosaic pattern. COP is also seen on Hrct. Mayberry J.P., ETAL thoracic manifestations of systemic autoimmune diseases, radiographic and high-resolution CT findings. Radiographics. 2020, 616 23 35. Disease. 32. A 39-year-old hypotensive man involved in an RTA was sent for an urgent CT of the abdomen and pelvis to evaluate for solid organ or bowel injury. Which one of the following statements concerning imaging in blunt trauma to the liver is false? A. Non-surgical treatment has become the standard of care in hemodynamically stable patients with blunt liver trauma. Chapter 9. Test paper 5, questions. 248. B. Hepatic lacerations demonstrate jagged edges. C. CT is the diagnostic modality of choice for the evaluation of blunt liver trauma in hemodynamically stable patients. D. CT features of blunt liver trauma include lacerations, subcapsular or parenchymal hematomas, active hemorrhage, juxtahepatic venous injuries, periportal low attenuation, and a flat inferior vena cava. E. Follow-up MRI is required in patients with high-grade liver injuries to identify potential complications that require early intervention. 35. 32. E. Follow-up MRI is required in patients with high-grade liver injuries to identify potential complications that require early intervention. Non-surgical treatment has become the standard of care in hemodynamically stable patients with blunt liver trauma. The use of helical CT in the diagnosis and management of blunt liver trauma is mainly responsible for the notable shift during the past decade from routine surgical to non-surgical management of blunt liver injuries. CT is the diagnostic modality of choice for the evaluation of blunt liver trauma in hemodynamically stable patients and can accurately accurately help identify hepatic parenchymal injuries, help quantify the degree of hemoperitoneum, and reveal associated injuries in other abdominal organs, retroperitoneal structures, and the gastrointestinal tract. The CT features of blunt liver trauma include lacerations, subcapsular or parenchymal hematomas, active hemorrhage, juxtahepatic venous injuries, periportal low attenuation, and a flat inferior vena cava. It is important that radiologists be familiar with the liver injury grading system based on these CT features that was established by the American Association for the Surgery of Trauma. CT is also useful in the assessment of delayed complications in blunt liver trauma, including delayed hemorrhage, hepatic or perihepatic abscess, post-traumatic pseudoaneurysm, and hemophilia, and biliary complications such as myeloma and bile peritonitis. Follow-up CT is needed in patients with high-grade liver injuries to identify potential complications that require early intervention. UNW, ETAL CT in blunt liver trauma. Radiographics. 2005, 25:87104. 33, C, hemangioma, although not 33, a 45-year-old man with proptoses of the right eye is referred for an MRI for further evaluation. MRI reveals a moderately large, well-defined intraconal retrobulbar mass, which is isointense to muscle on T1W images and markedly hyperintense to fat on T2W images. What is the most likely diagnosis? A. Retinoblastoma. B. Rhabdomyoma. C. Hemangioma. D. Orbital pseudotumor. E. Metastatic lymphoma. Tend to displace and surround adjacent structures, such as extraconal muscles and the optic nerve, rather than cause direct invasion. Osseous remodeling may be present, although bone erosion is rare. At MRI performed with T1 weighted sequences, cavernous malformation. Malformations are isointense relative to muscle. The lesions appear uniformly hyperintense on T2 weighted images with no flow voids. Internal septations may be identified on T2 weighted images. At multiphase CT, enhancement of cavernous malformations is poor on early arterial phase images, owing to the scant arterial supply. Delayed venous phase images demonstrate progressive filling of the mass from periphery to center, with complete filling within 30 minutes. This enhancement pattern may permit differentiation of cavernous malformations from other vascular lesions with rich arterial supply, such as capillary hemangioma, a pediatric diagnosis, hemangioperocytoma, and arteriovenous malformations. Rhabdomyosarcoma is the most common soft tissue malignancy of childhood and most common primary orbital malignancy. CT shows moderately well-defined to ill-defined margins, irregular shape, and mild-moderate contrast enhancement. Adjacent bony destruction occurs in 40%. Globe. Distortion and extension to the paranasal sinuses may also be seen. Calcification is rare unless post. Treatment. MR typically shows bright T2 signal, distinguishing rhabdomyosarcoma from other tumors such as scleroma, granulocytic sarcoma, lymphoma, and metastatic neuroblastoma. Con SN, secondary AR, orbital masses, CT and MRI of common vascular lesions, benign tumors, and malignancies. Saudi J. Ophthalmol. 2012, 26, 437383. Taylor TD, ETAL orbital neoplasms in adults, clinical, radiologic, and pathologic review. Radiographics. 2013, 33, 617 3958. Chapter 10. Test paper 5, answers. A 32-year-old woman is referred by her family doctor to the gynecology clinic with history of congestive dysmenorrhea, dyspareunia, fever, and vaginal discharge. She had used a coil regularly in the past, which was later discontinued due to recurrent bouts of pelvic inflammation. Which one of the following statements concerning pelvic inflammatory disease is false? A. Piosal pinks can have a high T1 signal. B. A tubular, fluid-filled structure with enhancing walls suggests piosal pinks. C. Delay in treatment can lead to tubo-ovarian abscess. D. Intense enhancement of inflamed areas on contrast-enhanced T1W MRI. E. High signal in inflammatory stranding in peritubal fat on T1 fat-suppressed images. 34. E. High signal in inflammatory stranding in peritubal fat on T1 fat-suppressed images. Pelvic inflammatory disease, PID, affects women of reproductive age and can lead to infertility, ectopic pregnancy, and chronic pelvic pain. In acute cases when dilated fallopian tubes are detected, it is extremely important to be able to differentiate tubal torsion from a piosal pinks. A tubal torsion and a hematosalpinx may have a similar appearance to that of a fluid-filled tube on T2 weighted and stir images on T1 weighted images. However, a fluid-filled tube has low signal intensity. Layering is common with hemorrhagic lesions, and tubal torsion may have a comma-shaped appearance. A piosal pinks may have a similar appearance to that of a hydrosalpinx, but a hydrosalpinx usually has thinner walls. An abscess usually has low T1 weighted and high T2 weighted signal, but there can be a large variation in the signal intensity on T1 weighted and heterogeneity on T2 weighted images. Thick, irregular walls are typical of abscesses. The T1 signal of piosal pinks / to abscess varies according to hemorrhagic/proteinaceous content. On post-contrast T1 weighted images, piosal pinks shows wall enhancement. Enhancement of the surrounding inflamed fat can also be evident. Inflammatory fat stranding is also seen on fat-suppressed T2 weighted sequences. Febronio M. ETAL acute pelvic inflammatory disease, pictorial essay focused on computed tomography and magnetic resonance imaging findings. Radial Bras. 2012, 45, 63 45 50. Tukvata, ETAL MR imaging in pelvic inflammatory disease, comparison with laparoscopy and U.S. Radiology. 1999, 210, 1209 16. Images. 35, a 40-year-old woman with short stature presence with early onset hearing loss. Diagnostic workup reveals micromelic dwarfism, diffuse demineralization, and thinning of cortical bone, mild scoliosis, and old fractures of the vertebral bodies and long bones. There was evidence of poor dentition. Which of the following is the most likely diagnosis? A. Hypophosphatasia. B. Osteogenesis. 16. 35. The osteogenesis imperfecta. Osteogenesis imperfecta is an inherited disorder that results from mutations in either the COL1A1 or COL1A2 gene of type I collagen. The disease is usually apparent at birth or in childhood, but more mild forms of the disease may not be apparent until adulthood. The disease is classified into types I4, with type I, the mildest form, being described in the question. The presenile hearing loss is caused by otosclerosis. The differential diagnosis can be resolved by the extraskeletal manifestations, blue sclerae, and dentinogenesis imperfecta. The other types are type 2, lethal perinatal, type 3, severe progressive, and type 4, moderately severe. Adam A. ETAL Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th N. New York, Churchill Livingstone, 2008:1092-3. 36. Osteogenesis imperfecta C, Paget disease D, osteoporosis E, achondroplasia. 36. A macrosomic neonate, secondary to maternal diabetes, is noted to be in mild respiratory distress following delivery by cesarean section, CS. A chest X-ray demonstrates mild cardiomegaly, mild hyperexpansion, and small pleural effusions of the lungs. No focal lung abnormality is seen. What is the most likely diagnosis? A. Respiratory distress syndrome B. Meconium aspiration C. Staphylococcal pneumonia D. Group B. Streptococcal pneumonia E. Transient tachypnea of the newborn. 37. A 6-year-old child is admitted. 36. E. Transient tachypnea of the newborn. Although RDS is seen in association with maternal diabetes and cesarean section, hyperexpansion is not a feature of RDS. Transient tachypnea of the newborn appears soon after birth for hours and has been identified as occurring with cesarean birth and infant sedation. Longer labor intervals, macrosomia of the fetus, and maternal asthma have also been associated. It may be accompanied by chest retractions, by expiratory grunting, or by cyanosis, which can be relieved with minimal oxygen. Recovery is usually complete within 3 days. The lungs are usually affected diffusely and symmetrically, and the condition is commonly accompanied by small pleural effusions. The clinical course of transient tachypnea is relatively benign when compared with the severity suggested by chest films. Radiographic resolution by the 2nd or 3rd day characterizes this entity and differentiates it from other possible disorders. If radiographic resolution is not complete by the 3rd day, or if respiratory symptoms persist longer than 5 days, an alternative diagnosis should be sought. Findings of transient tachypnea of the newborn on chest radiographs may include mild, symmetrical lung overaeration, prominent perihilar interstitial markings, and small pleural effusions. The radiographic appearance at times can mimic the diffuse, granular appearance of hyaline membrane disease, but without pulmonary underaeration. Neonates with transient tachypnea are usually delivered at term. Radiographic lung changes may also resemble the coarse, interstitial pattern seen with other causes of pulmonary edema, or the irregular pattern of lung opacification seen in meconium aspiration syndrome. Arthur R. The neonatal chest X-ray. Pediatric Spur Revelation 2001, 2:3-1123. Chapter 10. Admitted to the emergency department presenting with diffuse abdominal pain, arthralgia, and bilateral lower limb palpable purpura. Which of the following findings on an abdominal US examination is least expected? A. Iliocecal intussusception B. Bowel wall thickening. Chapter 9. Test paper 5, questions. 249. C. Multifocal hepatic lesions D. Bilaterally enlarged, echogenic renal cortices E. Ascites. 38. 10. Test paper 5, answers. 277. 37. C. Multifocal hepatic lesions Haynock-Schönlein purpura is the most common vasculitis of childhood affecting small blood vessels. Clinical manifestations may include non-thrombocytopenic purpura, arthritis, abdominal pain, gastrointestinal hemorrhage, and glomerulonephritis. Imaging is useful to depict end organ damage. Ultrasound findings may include bowel wall edema, submucosal and intramural hemorrhage, intussusception, hypoperistalsis, bowel dilatation, ascites, normal or enlarged echogenic kidneys, and also possible intramural hematomas within the urinary bladder and ureters. Non-specific findings on scrotal ultrasound may be identified such as hydroceles, scrotal wall thickening, and inflammation of the spermatic cord and epididymis. Kun-na-G, ETAL pediatric vasculitis, recognizing multi 38. All of the following are musculoskeletal manifestations of rheumatoid arthritis that can be seen on chest radiographs, except A. Subacromial abutment of humeral head B. Superior rib notching C. Global loss of shoulder joint space D. Erosion of medial aspect of clavicle E. Erosion supralaterally in the humeral head. 39. Multisystemic manifestations at body imaging. Radiographics. 2015, 35:849-65. 38. D. Erosion of the medial aspect of the clavicle bone. Changes of rheumatoid arthritis seen on chest X-ray include resorption of the lateral end of the clavicles, erosive arthritis of the shoulders, most commonly supralateral aspect of humeral head, global loss of shoulder joint space, superior rib notching, atrophy and rotator cuff tear. Sommer O.J., ETAL rheumatoid arthritis, a practical guide to state-of-the-art imaging, image interpretation, and clinical implications. Radiographics. A 46-year-old man with syncopal episodes is found to be profoundly hypoglycemic on each of the episodes. He is not on any anti-diabetic medication. What imaging investigation would you suggest for further evaluation? A. CT of the chest and liver B. CT of the brain C. MRA of the circle of Willis D. Dual-phase CT of the pancreas E. US of the abdomen. Radiographics. 2005, 25, 238198. 39. D. Dual-phase CT pancreas insulinomas are the most common functioning pancreatic endocrine tumors, PET, accounting for just over 40% of all functioning PETs. They have an incidence of 2 to 4 per million people each year. They tend to manifest earlier and have a smaller size than other functioning and non-functioning endocrine tumors. Insulinomas usually are sporadic, but they account for 10%-30% of functioning PETs in patients with multiple endocrine neoplasia, MEN1, and they have been reported in patients with neurofibromatosis type 1. In 1935, Whipple and Franz described the classic clinical triad of insulinomas, symptoms of hypoglycemia, low blood glucose, and relief of symptoms with administration of glucose. Hypoglycemia typically manifests during fasting or after exercise, and patients often self-medicate by eating frequent small meals. On CT and MR imaging, insulinomas are typically homogeneous and hyperenhancing. The use of coronal images may help differentiate these small hyperenhancing lesions from nearby. Lewis R.B., ETAL pancreatic endocrine tumor. Abdomen. 40. A 33-year-old woman with progressive congestive dysmenorrhea, deep dyspareunia, and infertility is being evaluated for possible endometriosis. All of the following are typical Mr. findings of endometriosis, except A. Hypointense cysts on T1W images B. Hyperintense cysts on T2W images C. Multilocular cysts D. Thick-walled cysts E. Hypointense wall thickening on T1W and T. Tumors, radiologic clinicopathologic correlation. Radiographics. 2010, 30:14:45-64. 40a. Hypointense cysts on T1W images findings of an adnexal mass with high T1 weighted signal and high T2 weighted signal, although slightly lower T2 signal than simple or functional cyst, is highly specific for an endometrioma. The main differential for high T1 weighted cysts are hemorrhagic functional cysts and mature cystic teratoma. Cystic teratoma is differentiated by means of T1 weighted fat-suppressed images. Endometriomas tend to have higher T1 and lower T2 signal than hemorrhagic cysts due to higher protein content and viscosity, described as T2 shading. Multifocal lesions and bilateral lesions also favor endometriosis. Hemosiderin-laden macrophages combined with the fibrous nature of the cyst wall give it a low signal intensity appearance on both T1 and T2 weighted images. Wall thickening, septae, and nodularity are also recognized. Woodward P.J., ETAL endometriosis, radiologic pathologic correlation. Radiographics. 2001, 21, 1193-16. Chapter 10. Test Paper 5, Answers. 278. T2W images. 41, a 6-year-old boy presents with increasing pain within his upper back, which came on insidiously over a few weeks. The child is otherwise well. A radiograph of his thoracic spine reveals collapse of the T9 vertebral body. The disc spaces are preserved, there is no kyphosis, and no involvement of the posterior elements. Which of the following is the most likely diagnosis? A. Ewing sarcoma B. Metastasis C. Tuberculosis D. Fracture E. Eosinophilic granuloma. 42, a 6-year-old boy presents with progressive proptoses of the 41, E. Eosinophilic granuloma. The vast majority of vertebra plana lesions in relatively healthy children are caused by an eosinophilic granuloma. The other available options are all possible but less common differential diagnoses. There is usually preservation of the disc space and no kyphosis. The posterior elements are rarely involved. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011. Sutton D. Textbook of Radiology and Imaging, 7th ed. Edinburgh, Churchill Livingstone, 2003. 42, D. Dermoid cysts. Dermoid cysts represent the right eye. CT shows a homogeneous hypodense mass in the upper outer corner of the right orbit associated with thinning of the roof. No infiltration of the surrounding fat is evident. On MRI, the mass returns a similar signal to that of orbital fat and showed thin ring enhancement. What is the diagnosis? A. Lymphoma B. Pleomorphic adenoma of lacrimal gland C. Epidermoid cyst D. Dermoid cyst E. Sebaceous cyst. Most common congenital lesion of the orbit and account for 1/3 of all childhood orbital tumors. CT shows an ovoid, well-demarcated cystic lesion. There may be fat 50% or calcification 15%. Present. Bone remodeling and thin rim enhancement is described. The majority occur in the extraconal location, occupying the superlateral aspect of the anterior orbit, related to the frontozygomatic suture. MRI shows high signal on T1 weighted images, if containing fat or proteinaceous material with low to isointense signal on T2 weighted images. Thin rim enhancement is seen on T1 FS images post-administration of gadolinium, unless the lesion has ruptured. Grant L.A., Griffin N., Granger and Allison's Diagnostic Radiology Essentials. Orbital tumors. New York, New Cyst. 43, a 42-year-old man presented with right-sided proptoses with mass in the inner canthus of the eye. An axial CT scan showed soft tissue density and expansion of the right anterior. Chapter 9. Test Paper 5, Questions. 250. Ethmoid air cells bulging into the orbit. The extraocular muscles were displaced but not involved. What is the diagnosis? A. Encephalocele B. Anterior ethmoid mucocele C. Destructive midline granuloma D. Wagner's disease E. Esthesia neuroblastoma. York, New York, Churchill Livingstone Elsevier Limited, 2013:826. Jung W.S., ETAL. The radiological spectrum of orbital pathologies that involve the lacrimal gland and the lacrimal fossa. Korean J. Radiol, Off J. Korean Radiol SOC 2007, 8-433642. 43, B. Anterior ethmoid mucocele paranasal sinus mucoceles are benign, expansal cystic masses covered by respiratory epithelium, resulting from accumulation and retention of mucus secretion in cases where the sinus drainage is obstructed. Obstructed. They primarily occur in the frontal sinuses. Sinuses, 60% 65%, but may also be found in ethmoid sinuses, 20% 25%. Usually, mucoceles are seen as an isodense or mildly hyperdense sinus opacity in relation to the cerebral tissue, but in cases of acute infection it may appear as a more dense and peripherally enhanced image. The neighboring bone structure is remodeled with areas of thickening, expansion, and erosion. Additionally, in the areas of greater fragility, one may observe herniation into adjacent structures, displacing structures rather than invading them. Invasion would suggest malignancy. The radiological appearance at MRI varies with the time of evolution of the disease. Initially, the contents will be predominantly aqueous, so the corresponding image will be hypointense on T1 weighted sequences and hyperintense on T2 weighted sequences. Over time, the protein contents may increase, resulting in hyperintense images both on T1 weighted and T2 weighted sequences. Esthesia neuroblastoma. 44. A 62-year-old man who has undergone solid organ transplant is found to be profoundly neutropenic and presents with progressive fever, cough, and shortness of breath. He is acutely unwell. Chest X-ray shows bilateral patchy air space opacities, and bronchoalveolar lavage showed aspergillus organisms. Hrct is organized to confirm pulmonary invasive aspergillosis. All the following are typical imaging features except A. Nodules with surrounding ground glass change B. Pulmonary sequestra C. Peripheral wedge-shaped consolidation D. Air crescent sign E. Central bronchiectasis. Carvalho BV, ETAL typical and atypical presentations of paranasal sinus mucocele at computed tomography. Radial Bras. 2013, 46, 63725. 44. E. Central bronchiectasis angioinvasive pulmonary aspergillosis occurs almost exclusively in immunocompromised patients with severe neutropenia. Characteristic CT findings include nodules surrounded by a halo of ground glass attenuation, halo sign, or pleural-based, wedge-shaped areas of consolidation. In neutropenia patients, the halo sign is highly suggestive of angioinvasive aspergillosis. However, a similar appearance has been described in infection by mucorales, candida. Candida, herpes simplex virus, HSV, cytomegalovirus, CMV, Wegener's granulomatosis, Kaposi sarcoma, and hemorrhagic metastases. Separation of fragments of necrotic lung, pulmonary sequestra, from adjacent parenchyma results in air crescent similar to those seen in mycotomas. The air crescent sign is usually seen after initiation of treatment and with resolution of the neutropenia. Airway invasive aspergillosis shows multiple centrilobular nodules and the tree and bud pattern. Frankwood T, ETAL spectrum of pulmonary aspergillosis. 45. A 2-year-old child presents with fever, erythema of the oral mucosa with chest and abdominal pain. Echocardiography reveals the presence of a coronary arterial aneurysms. An underlying vasculitis is suspected. Which of the following statements is least accurate in this clinical setting? A. Aneurysms are typically seen in the proximal segments of the coronary arteries. B. Aneurysms less than 5 mm in diameter are considered small. C. Smaller aneurysms have a higher likelihood of thrombosis. D. Multiple coronary artery aneurysms are more common than isolated aneurysms. E. The most common site for a coronary aneurysm is in the left anterior descending artery. 46. A 61-year-old man with difficult aspergillosis, histologic, clinical, and radiologic findings. Radiographics. 2001, 21, for 82537. Chapter 10. Test Paper 5, Answers. 279. 45. C. Smaller aneurysms have a higher likelihood of thrombosis. Kawasaki's disease is a common pediatric vasculitis of medium-sized vessels, with coronary vasculitis being the hallmark manifestation. It is the leading cause of acquired heart disease in children in developed countries. Coronary arterial aneurysms typically occur within the subacute phase of the disease, and may be associated with sudden cardiac death. The aneurysms typically develop in the proximal segments of major coronary arteries, and affect the left anterior descending artery followed by the proximal right coronary arteries in frequency of location. Smaller aneurysms, 5 mm in diameter, are more likely to regress than larger aneurysms, greater than 8 mm in diameter, which have a higher likelihood of thrombosis and infarction. Kunna G, ETAL pediatric vasculitis, recognizing multisystemic manifestations at body imaging. Difficulty in swallowing was sent by his family doctor for a barium swallow. The examination showed a smooth filling defect in the mid-lower esophagus with minor holdup of contrast and proximal esophageal dilatation. CT performed for further evaluation did not show any extraesophageal organ involvement or lymphadenopathy. The most common mesenchymal tumor of the esophagus is A. Lipoma B. Gastrointestinal stromal tumor C. Hemangioma D. Leiomyosarcoma E. Leiomyoma. Imaging. Radiographics. 2015, 35:84965. 46. E. Leiomyoma. Leiomyomas are neoplasms of mature smooth muscle cells and are the most common benign esophageal neoplasm, although they are about 50 times less common than esophageal carcinoma. They are also the most common mesenchymal tumors of the esophagus, unlike in the remainder of the gastrointestinal tract, where gysts predominate. Esophageal leiomyomas are nearly twice as common in men as in women, and have been reported in patients between 4 and 81 years of age, although they rarely occur in the pediatric population. Most patients are asymptomatic, but dysphagia and pain may develop, depending on the size of the lesion and amount of encroachment on the esophageal lumen, in contrast to patients with malignant esophageal tumors. Affected individuals usually have long-standing symptoms, with a duration of more than 2 years in most cases. Treatment options include endoscopic resection, surgical enucleation, and observation. Esophageal leiomyomas have a benign clinical course and typically do not recur after surgery. Lewis R.B., ETAL esophageal neoplasms, radiologic pathologic correlation. Radiograph. Leiomyoma. 47. A 22-year-old woman who had undergone a cesarean section presents with cyclic voiding symptoms but no hematuria. Cystoscopy shows a filling defect and MRI is performed. Axial T2W MRI shows hypointense irregular focal wall thickening on the left posterolateral aspect of the bladder, without any fat stranding or associated lymph nodes, suggesting intrinsic bladder endometriosis. Which of the following statements is false regarding deep pelvic endometriosis? A. Subperitoneal invasion of endometriotic tissue must exceed 5 mm. B. Endometriotic nodules can have high T2W signal. C. Low signal nodular thickening of uterosacral ligament on T2W images. D. Ureteric endometriosis is mostly intrinsic. E. Obliteration of pouch of Douglas is recognized in advanced disease. Radiographics. 2013, 33:1083-110. 47. D. Ureteric endometriosis is mostly intrinsic. Deep pelvic endometriosis is defined as subperitoneal invasion by endometriotic lesions that exceeds 5 mm in depth. Involvement of anatomic structures such as the uterosacral ligaments or the vaginal or rectal wall should be suspected when these structures have a hypointense thickened or nodular appearance on T2 weighted images. Intermingled high T2 signal would be secondary to ectopic endometrial glands. On T1 weighted or fat-suppressed T1 weighted MR images, these foci may have either high or low signal intensity, depending on the presence or absence of bloody content. Some endometriomas may show restricted diffusion on DWI, probably due to intracystic blood clots. Enhancement may or may not occur post-contrast, depending on the proportions of inflammatory reaction, glandular tissue, and fibrosis. Bladder endometriosis should be considered in anyone who presents with urinary tract symptoms after having undergone hysterectomy or other gynecologic surgical procedure. Because vesical endometriosis seldom invades the mucosa, MR imaging may show abnormalities, although cystoscopy is normal. As with bladder involvement, extrinsic endometriosis is the most common form of ureteral involvement. On MR imaging, ureteral endometriosis usually appears as irregular hypointense nodules on T2 weighted images. Deep retroperitoneal endometriotic lesions of the posterior compartment involve the rectovaginal pouch, retrocervical area, uterosacral ligaments, posterior vaginal fornix, rectovaginal septum and rectum. Obliteration of the pouch of Douglas occurs when retrocervical lesions extend to the anterior rectal wall. Coutinho AJR, ETAL MR imaging in deep pelvic endometriosis, a pictorial essay. Radiographics. 2011, 31-2549-67. Chapter 10. Disease. Chapter 9. Test paper 5, questions. 251. 48, a 7-year-old boy fell off a bike onto his outstretched left hand. X-ray showed a fracture of the left distal radius involving the epiphyseal plate that extends into the metaphysis. The epiphysis was split into 2 fragments. What is the Salter-Harris classification? A. 1B, 2C, 3D, 4E, 5. 4. Chapter 10. Test paper 5, answers. 280. 48. D. For physial Salter-Harris fractures are divided into 2 categories on the basis of the involved physial regions. 1. Horizontal fractures without involvement of the germinal or proliferative zone of the physis, and 2. Longitudinal fractures that extend through all zones of the physis into the epiphysis. Horizontal fractures, Salter-Harris types I and 2, result in bridge formation in 25% of cases, whereas longitudinal fractures, Salter-Harris types 3 and 4, result in bridge formation in 75% of cases. Jamie C. ETAL. D. For physial Salter-Harris fractures are divided into 2 categories on the basis of the involved physial regions. 1. Horizontal fractures without involvement of the germinal or proliferative zone of the physis, and 2. Longitudinal fractures that extend through all zones of the physis into the epiphysis. Horizontal fractures, Salter-Harris types I and 2, result in bridge formation in 25% of cases, whereas longitudinal fractures, Salter-Harris types 3 and 4, result in bridge formation in 75% of cases. Jamie C. ETAL MR imaging of normal epiphyseal development and common epiphyseal disorders. 49, an 81-year-old man with bilateral calcified and uncalcified pleural plaques, basal predominant fibrotic lungs, and unilateral pleural effusion is sent for a CT scan with high suspicion of primary pleural mesothelioma. CT and pleural fluid aspirate confirmed mesothelioma. Which of these is not a feature of unresectability? A. Extension into peritoneal cavity. B. Involvement of endothoracic fascia. C. Pericardial involvement. D. Multiple sites of extension into the chest wall. E. Direct extension into the ribs and spine. 50, a 70-year. Radiographics. 2014, 34, 2 for 4971. 49. B. Involvement of endothoracic fascia. Malignant mesothelioma occurs mainly in the pleura and peritoneum, but can arise in the pericardium or tunica vaginalis testis. It is the most common primary neoplasm of the pleura and has a strong association with asbestos exposure, particularly crucidolite. Mesothelioma is not known to arise from plagues. There is a new TNM staging system for diffuse malignant pleural mesothelioma that emphasizes the criteria for determinate local tumor extension and regional lymph node status to identify patients with potentially curable early disease T1A and B, potentially resectable but not necessarily curable T2 and T3, and unresectable local tumor spread T4. Signs of unresectability include multifocal extension into chest wall with or without rib or spine destruction, extension through diaphragm into peritoneum, extension into contralateral pleura, extension into mediastinal organs, extension through pericardium, and direct extension into heart. Localized tumor extension into the endothoracic fascia, T3, is potentially resectable. 70-year-old man with a history of weight loss and iron deficiency anemia is referred for a CT colonography study. There is no malignancy on the scan, but a 5 cm cystic structure is seen next to the distal ileum, in keeping with a duplication cyst. The most common site of a duplication cyst of the gastrointestinal tract is the A, esophagus B, stomach C, duodenum D, jejunum E, ileum. Resectable. Roche HD, ETAL asbestos, when the dust settles, an imaging review of asbestos-related disease. Radiographics. 2002, 22, S16784. 50. Ileum enteric duplication cysts are an uncommon congenital abnormality. They can occur anywhere along the digestive tract on the mesenteric side. The small intestine is most commonly involved. Type I, Type 2. Type 3, Type 4, Type V. Chapter 10. Test Paper 5, Answers. 281. With the order from most to least common being the ileum, jejunum, and duodenum. Most duplication cysts manifest during the first year of life, although some occasionally manifest in older patients. Children can present with a variety of symptoms including abdominal distension, vomiting, bleeding, a palpable abdominal mass, and rarely urinary frequency and hesitancy. Complications include perforation, intussusception, bowel obstruction from adjacent pressure or mass effect, volvulus, and associated malignancy. Malignant lesions arising from duplication cysts are rare, particularly in children. Tong SC, ETAL ileocecal enteric duplication cyst, radiologic pathologic correlation. Radiographics. 2002, 22:12 17 22. Ileum. 51, a 33-year-old woman is referred by her family doctor to the infertility clinic for further investigations to identify any potentially treatable cause of infertility. Which one of the following statements regarding intracavitary uterine abnormalities as a cause of infertility is false? A. Uterine synechia is a complication of D&C. B. Synechal infertility and cervical stenosis. Steinkalea J.A., ETAL female infertility, a systematic approach to turbinates and paranasal sinuses without associated soft tissue masses. Chest radiograph of the same person done to exclude infection showed multiple nodules of varying sizes. A. Churg-Strauss disease. B. Ethmoid carcinoma. C. Polyarteritis nodosa. D. Granulomatosis with polyangiitis. E. Leprosy. Radiologic imaging and diagnosis. Radiographics. 2009, 29, 513 53 70. 52. D. Granulomatosis with polyangiitis. CT scanning is likely to reveal a common mucosal thickening similar to that encountered in chronic sinusitis. However, the presence of bony erosions of the sinonasal wall is very suspect of the diagnosis of a granulomatous disease. Bone erosion commonly affects the lamina papyracea, orbital wall, intersinonasal wall, and nasal septum. Bone destruction usually involves the nasal septum, and then extends to the sinonasal wall, destroying the turbinates. Differential diagnoses including traumatic lesions, accidental, iatrogenic, or toxic lesions, cocaine abuse, chromium salts, should be considered. Isolated septal perforation should suggest the diagnosis of GP. There are no specific imaging findings to distinguish GP from lethal midline granuloma, but the destructive lesions seem to be more extensive in lethal midline granuloma. Pulmonary nodules and masses are the most common radiologic findings of Wegener's granulomatosis. Benudaba F. ETAL sinonasal Wegener's granulomatosis, CT characteristics. Neuroradiology. 2003, 45:95-9. Martinez F. ETAL common and uncommon manifestations of Wegener granulomatosis at chest CT, radiologic pathologic correlation. Radiographics. 2012. Leprosy. 53, a 30-year-old sustains a knee injury while skiing. MRI shows that there is a high signal in the lateral femoral condyle and the posterolateral part of the lateral tibial plateau. What is the most likely injury? A. ACL. B. PCL. Chapter 9. Test Paper 5, Questions. 252. C. MCLD, LCLE, MPFL, medial patellofemoral ligament. 2012, 32:51-69. 69. 53. A. ACL. The pivot shift injury is a non-contact injury commonly seen in skiers or U.S. football players. The resulting bone contusion, pivot shift edema, pattern involves the posterior aspect of the lateral tibial plateau and the mid-portion of the lateral femoral condyle. The exact location of the lateral femoral condyle injury depends on the degree of flexion of the knee at injury. Another recently described bone contusion pattern associated with the pivot shift injury is edema within the posterior lip of the medial tibial plateau. Pivot shift edema is typically associated with ACL tear, most commonly mid-substance. Chapter 10. Test Paper 5, Answers. 282. Dashboard edema is seen at the anterior aspect of the tibia and occasionally at the posterior surface of the patella. The associated soft tissue injuries include disruption of the PCL, most commonly mid-substance, posterior joint capsule. Hyperextension of the knee can result in kissing contusion involving the anterior aspect of the tibial plateau and the anterior aspect of the femoral condyle. ACL, PCL, and meniscal injury can be associated depending on the force. The classic bone contusion pattern seen after lateral patellar dislocation includes involvement of the anterolateral aspect of the lateral femoral condyle and the inframedial aspect of the patella. This is associated with tear of MPFL. With clip injury, pure valgus stress, bone marrow edema is usually most prominent in the lateral femoral condyle secondary to the direct blow, whereas a second smaller area of edema may be present in the medial femoral condyle secondary to avulsive stress to the MCL, mostly. At the ligament. 54, a 14-year-old girl with chronic constitutional symptoms and sinonasal disease presents to the outpatient department. A CT of the paranasal sinuses reveals diffuse sinusitis and thickening of the paranasal sinus walls. On a plain chest radiograph, a cavitating pulmonary lesion is identified. Which of the following vasculitides would be the most likely diagnosis? A. Kawasaki's disease. B. Cogan syndrome. C. Takayasu arthritis. D. Granulomatosis with polyangiitis. E. Polyarteritis nodosa. 55. A 77-year-old man with a high-risk occupational history and progressive limitation of exercise tolerance was sent for a staging CT of the chest to investigate a persistent right-sided pleural effusion. All of the following pulmonary CT features are suggestive of asbestos exposure, except A. Basal fibrosis. B. Calcified pleural plaque. C. Diffuse pleural thickening. D. Round atelectasis. E. High-density consolidation. 56. A 65. Femoral attachment. Sanders TG, ETAL bone contusion patterns of the knee at MR imaging, footprint of the mechanism of injury. Radiographics. 2020, S13551. 54. D. Granulomatosis with polyangiitis. Granulomatosis with polyangiitis, GPA, previously known as Wegener's granulomatosis, affects small to medium-sized vessels and most commonly involves the upper and lower respiratory tracts and kidneys. In comparison to adults, children are more likely to have multi-organ involvement with renal disease, subglottic stenosis, nasal deformity, and pulmonary findings. Differential diagnosis of GPA may include those that present with pulmonary renal features. Features such as mixed connective tissue diseases, Goodpasture syndrome, or systemic lupus erythematosus. Takayasu arthritis is a large vessel vasculitis with characteristic abnormalities of the aorta and its main branches. Kawasaki's disease and polyarteritis nodosa, PAN, are medium vessel vasculitides. The hallmark imaging feature in Kawasaki's disease includes coronary artery aneurysms. In PAN, angiographic findings of aneurysms, stenoses, or occlusions of medium-sized vessels is a key diagnostic criterion. This is predominantly seen in renal and mesenteric arteries, although not pathognomonic. Cogan syndrome is an autoimmune disorder characterized by interstitial keratitis and bilateral audiovestibular deficits. It may be associated with a systemic vasculitis and typically presents in young adulthood. Kunna-G, ETAL pediatric vasculitis, recognizing multisystemic manifestation. 65-year-old known diabetic woman is acutely unwell and presents with increasing epigastric tenderness. She is referred by the surgeons for an urgent contrast-enhanced CT of the abdomen. The CT shows features consistent with manifestations at body imaging. Radiographics. 2015, 35:84965. 55. High-density consolidation pleural disease is the most commonly encountered manifestation of asbestos-related disease. Benign pleural effusions are thought to be the earliest pleural-based phenomenon. The most common manifestation of asbestos exposure is pleural plaques that usually arise from the parietal pleura, but may arise from visceral pleura. Calcification is reported in 10%, 15%. The classic distribution of plaques is the posterolateral chest wall, the dome of the diaphragm, virtually pathognomonic, and the mediastinal pleura. The apices and costophrenic angles are typically spared. Diffuse pleural thickening is less specific for asbestos exposure. Asbestos-related round atelectasis is also known as asbestos pseudotumor and is related to fibrosis in the superficial layers of the pleura. Asbestosis is the term given to lung fibrosis caused by asbestos. The changes are more pronounced in the lower lobes and subpleurally, but often extend to involve the middle lobe and lingula. Malignant mesothelioma and bronchogenic carcinoma are known associations. High-density consolidation is typical of amiodarone lung changes. Roche HD, ETAL asbestos, when the dust settles in imaging. With emphysema 2 gastritis. Gastritis. All of the following are expected CT findings except A. Air in the stomach wall. B. Pneumoperitoneum. C. Pneumobilia. D. Portal venous gas. E. Irregular gastric mucosal fold. Imaging review of asbestos-related disease. Radiographics. 2002, 22, S16784. Chapter 10. Test paper 5, answers. 283. 56. C. Pneumobilia. Of all the hollow viscera, the stomach is the least commonly affected by gas-forming infections. Of the 30 reported cases in the literature, caustic ingestion, 37%, and alcohol abuse, 22%, were found to be the most common causes. Other predisposing conditions include recent gastroduodenal surgery, trauma, and gastric infarction. Caustic ingestion of acid is thought to promote coagulative necrosis of the gastric lumen, whereas ingestion of an alkaline substance leads to liquefactive necrosis. In either case, the end result is mucosal damage and superinfection with gas-forming bacteria. There are no predilections with regard to age, sex, or diabetic status. Clinical manifestation may be dramatic, ranging from acute sepsis to gastric hemorrhage and, rarely, vomiting of the necrotic stomach cast. CT is considered the modality of choice for detection of intramural gas and evaluation for the presence of pneumoperitoneum or portal venous gas. CT may also demonstrate irregular mucosal fold thickening and may be used to monitor response to treatment or disease progression. An important differential diagnosis to consider is benign gastric emphysema. Gas collections form within the gastric wall without associated infection by gas-forming organisms. Gas may enter the wall from the lumen, peritoneal surface, or esophageal, or duodenal connection, and is usually associated with violent coughing, vomiting, or severe obstructive pulmonary disease. Gastric fold inflammation and thickening are not present, and the patient is usually asymptomatic with spontaneous resolution expected. Graysonda, ETAL emphysema 2 infections of the abdomen and pelvis, a pictorial review. Radiographics. Thickening. 57, a 31-year-old woman was referred for a hysterosalpingogram for assessment of tubal anatomy and patency. The left fallopian tube was normal but no pelvic spillage was observed on the right, subject to proximal obstruction of the tube on the right. Which of the following conditions is not a cause of obstruction in the fallopian tube? A. Granulomatous salpingitis. B. Intraluminal endometriosis. C. Congenital atresia. D. Caritubal adhesions. E. Tubal spasm. 58, a 29-year-old man with history of discharge from the right ear underwent a CT of the temporal bones for further evaluation. Coronal CT images showed enlargement of the epitympanic recess and erosion of the walls and scutum with an associated soft tissue mass. Only fragments of the ossicular chain could be identified. What is the diagnosis? A. Cholesterol granuloma. B. Acquired attic cholesteatoma. C. Congenital cholesteatoma. D. Carcinoma of the middle ear. E. Malignant otitis externa. Radiographics. 2002, 22:54361. 57, D. Caritubal adhesions. The differential diagnosis of tubal occlusion typically includes tubal spasm, infection, and prior surgery. Rare causes include granulomatous salpingitis due to tuberculosis, intraluminal endometriosis, parasitic infection, and congenital atresia of the fallopian tubes. When tubal occlusion in the proximal or interstitial portion of the fallopian tube is seen at hysterosalpingography, a tubal spasm should be considered as the possible cause. Delayed radiography may be performed to help differentiate tubal spasm from true tubal occlusion. A spasmolytic agent such as glucagon also may be administered to relax the uterine muscle and relieve a tubal spasm. Peritubal adhesions show peritubal pooling of contrast material rather than occlusion of fallopian tubes. Stein-Kaleo J.A., ETAL female infertility, a systematic approach to radiologic imaging and diagnosis. Radiographics. 2009, 29, 513-5370. Chapter 9. Test Paper 5, Questions. 253. 59, an 8-year-old boy presents with a 5-week history of 58, B. Acquired attic cholesteatoma. Cholesteatomas are composed of densely packed desquamated keratinizing squamous cells, arising from a peripheral shell of inward-facing epithelium. The role of CT is to assess the extent of disease and exclude complications. Key findings on Hrct include soft tissue opacification in the attic, additus, non-dependent location, and slash or mastoid air cells, erosion of the scutum, disruption of ossicular chain, long process of incus erosion is common, presence of disease in sinus tympani and erosions of the tegment tympani, semicircular canal, facial nerve canal, and inner ear. In cases of clinical suspicion of intracranial extension, perform contrast CT/MRI to rule out intracranial complications. Congenital cholesteatoma is difficult to differentiate from acquired type, but clinical features help. It is commonly seen in children with intact tympanic membrane and absence of previous otologic disease. Of left hip pain and limp. Several previous pelvic X-rays were normal. A bone scan shows reduced uptake in the left femoral epiphysis. A line drawn from the lateral aspect of the femoral neck intersects the femoral head. What is the most likely diagnosis? Umbersu A. ETAL soft tissue attenuation in middle ear on Hrct, pictorial review. Indian J. Radial imaging. 2012, 22:298-304. 59, B. Transient synovitis. Acute transient synovitis is the most common non-traumatic cause of hip pain in young children. It tends to affect children between 2 and 9 years of age, and boys are affected 2 to 4 times more often. Where history is typical, no imaging may be required. Ultrasound can be used to identify the effusion. Initial bone scan uptake can be reduced, mimicking SUFE, but can increase later on. Chapter 10. Test Paper 5, Answers. 284. Juvenile Juvenile arthritis affects children above 5 years of age. Radiographs may show erosions and loss of joint space. MRI and ultrasound are more sensitive for soft tissue changes, allowing demonstration of synovitis, distinguishing ponus from simple effusion, and identifying cartilage destruction and cortical erosions. Septic arthritis is an emergency. The majority of patients are less than 2 years old and are usually unwell with pain on passive movement of the hip. Avascular necrosis, AVN, of the femoral head is a condition induced by compromised blood supply, resulting in progressive destruction of bone. It is most commonly idiopathic, PERTAS, but may be seen following trauma, infection, steroid treatment, and in association with hematological diseases, such as sickle cell anemia. PERTAS disease usually affects children between 4 and 10 years of age and is more common in boys. Plain radiography is insensitive at early changes. The epiphysis may appear small, sclerotic or flattened with subchondral lucency or more marked. Fragmentation. Where symmetrical changes are seen, hypothyroidism or epiphyseal dysplasia should be considered. Meyer's dysplasia mimics PERTAS disease unilaterally by appearance but is asymptomatic. Jane N. ETAL radiological approach to a child with hip pain. Clin radial. Previous pelvic X-rays were normal. A bone scan shows reduced uptake in the left femoral epiphysis. A line drawn from the lateral aspect of the femoral neck intersects the femoral head. What is the most likely diagnosis? A. SUFE. B. Transient synovitis. C. PERTAS disease. D. Developmental dysplasia of the hip. E. Sickle cell disease. 60. A 6-year-old boy with abdominal pain and jaundice was sent for a specialist review because the GP identified abnormal LFTs, raised bilirubin, raised AST, and ALT. Viral serology for hepatitis B and C were negative. 24-hour urinary copper excretion was greater than 100 microgram, normal 40 microgram. An abnormal ring was noted in the eye on slit lamp examination. All of the following can be seen on US of the abdomen, except A. Mild hepatomegaly, B. Small echogenic liver, C. Abnormally large kidneys, D. Ascites, E. Abnormally large spleen. Radial. 2013, 68, 11 67 78. 60. C. Abnormally large kidneys. There are several causes of chronic liver failure in children: chronic hepatitis, hepatitis B and C, biliary atresia, drug-induced, e.g., paracetamol, alpha-1 antitrypsin deficiency, Wilson's disease, cystic fibrosis, IBD, inflammatory bowel disease, Budd-Chiari syndrome, TPN, total parenteral nutrition, induced and so on. Abnormal sweat test, greater than 60 mol/L of sodium chloride, suggests CF, while reduced serum copper and ceruloplasmin and raised 24-hour urinary copper suggests Wilson's disease. US shows hepatomegaly, echogenic liver, splenomegaly, ascites and varices. Kaiser-Fleischer rings from copper deposition in the eye are pathognomonic, but may require slit lamp examination to visualize. Adolescent patients can present with neurological symptoms. Symptoms. Enlarged kidneys are not a feature of Wilson's disease, and may be seen in the acute phase of glomerulonephritis, ATN, renal vein thrombosis, amyloidosis, lymphoma, diabetes, glycogen storage disease, polycystic kidney disease and so on. Dannert W. Radio